We're going to look at scleroderma and connective tissue disease, ILD, fibrotic HP, sarcoidosis, ANCA vasculitis, LAM, COP. And we'll talk about mycophenolate and anti-MDA5. So the first trial is the SENSCIS, and then we're going to talk about Nintedanib in scleroderma ILD. So New England Journal of Medicine 2019, FDA approved in September 2019. So we're looking at Disler trial, looking at 1 year, 576 patients, Nintedanib versus placebo. Again, the Impulsus already trial showed Nintedanib for IPF. This is for scleroderma ILD, decreased the forced vital capacity was only decreased by 52 per year as opposed to 93 per year in the placebo. Diarrhea did happen 75% of the time with the Nintedanib. You could always lower the dose to 100 BID instead of TID, or instead of, is it 120? Yeah, 100 BID instead of TID. Who benefits most? The scleroderma ILD patients with UIP pattern on high-res CT had the strongest forced vital capacity benefit. The standard algorithm is the mycophenolate backbone immunosuppression, and if you progress despite MMF, then you add Nintedanib as per the SENSCIS trial. This is the SENSCIS 2019 trial. Okay. The SLS-II and LOTUSS trial. So SLS-II is Tashkin Lancet Respiratory Medicine 2016. LOTUSS was a safety analysis, CANA and CHEST 2016. We're looking at mycophenolate versus oral Cytoxan or cyclophosphamide for 24 months. Basically, it showed identical forced vital capacity improvement, significantly fewer serious side effects, adverse events with MMS versus Cytoxan. So that's why mycophenolate became the standard immunosuppressant in connective tissue disease, ILD. CellCept is used for scleroderma ILD, rheumatoid arthritis, myositis ILD, NSIP. If you progress despite on MMF, then you add the Nintedanib as per the SENSCIS framework. Never cyclophosphamide or as the first line when MMF is available. It's safe, same efficacy, and far safer. Okay. The next trial is Champ Morissette Journal of Lancet Respiratory Medicine in 2020, and the INBUILD Hypersensitivity Pneumonitis subgroup. That was the Nintedanib trial for non-IPF patients. So basically, the forced vital capacity change, azathioprine versus MMF, negative 3.1% versus negative 2.4%. Both arms had comparable forced vital capacity. So there's a 1 year trial. Fibrotic hypersensitivity pneumonitis, azathioprine and MMF are both useful in equal in terms of their change. The INBUILD HP subgroup in the placebo was 144 cc's per year versus 68 per year. So the treatment hierarchy is antigen avoidance. So if you have parrots, let's say, and that's causing your hypersensitive pneumonitis, you avoid that. Then you give MMF or azathioprine as the immunosuppression, and if it progresses, you give Nintedanib as per the INBUILD hypersensitivity pneumonitis subgroup. That was in 2019. So remember, SENSCIS was 2019. INBUILD is 2019. CHAMP 2020. So that is the fibrotic hierarchy: antigen avoidance, MMF or azathioprine, and then Nintedanib. Then we have sarcoidosis discussion, Kalman et al. In 2025, New England Journal of Medicine. And this when to treat all the way back in CHEST 1997, Pietinalo. And of course, ATS 2025 update with the New England Journal of Medicine study. So PredMeth showed that methotrexate was non-inferior when it came to forced vital capacity change. So that's what we're looking at, forced vital capacity change at 24 weeks, 138 patients, the PredMeth trial. So methotrexate advantages equal forced vital capacity improvement, avoids the steroid side effects, weight gain, diabetes. It's It's already known as a second line, and it's slower onset though. The prednisone advantages: faster onset, still preferred in cardiac sarcoid and neurosarcoid and life-threatening ocular stuff, but it has long-term toxicity. When do you treat? So that's based on CHEST 1997. If you're symptomatic progressive pulmonary or sarcoid, cardiac, neurosarcoid, ocular, hypercalcemia. But if you're asymptomatic stage 1 and 2, watchful waiting, because stage 1, 65% remit spontaneously. So once again, forced vital capacity was improved on prednisone and methotrexate by the same amount. So you could choose based on your side effect profile. Methotrexate seems to be in for sarcoidosis. Refractory sarcoidosis is the next trial, Baumann et al. In the Blue Journal 2006. What's there to use? And the answer is infliximab, Rituxan 5 milligram per kilogram on weeks 0, 2, and then every month and a half. So chronic pulmonary sarcoidosis, refractory to steroids and immunosuppression, 138 patients. It improved, and your SGRQ was improved as well. First randomized controlled trial demonstrating biologic efficacy in sarcoidosis. This is the proof of concept of the TNF-alpha pathway. The greatest benefit was in high disease burden. Extrapulmonary involvement, higher disease burden got the most benefit. Screen tuberculosis first. You have to do the quantiferon gold test and the chest x-ray. Treat latent TB before you start the Rituxan. So refractory sarcoidosis, so prednisone 20 to 40 milligrams a day. You add methotrexate or azathioprine as steroid sparing. And then if it's refractory, you use infliximab or adalimumab. And then you screen TB at step 3. Hydroplaquenil is for skin and hypercalcemia only. So look at the bottom again. We've gone over this. So Baumann et al. Back in 2006 showing the treatment for refractory sarcoidosis. Then we have New England Journal of Medicine 2010, the RAVE trial and the main Ritsan. So now we're looking at ANCA vasculitis induction and maintenance. Some of the updates here: Rituxan has replaced cyclophosphamide for ANCA vasculitis induction and maintenance. RAVE trial, 197 patients, and the main Ritsan looking at 115 patients. Remission off prednisone at 6 months, you could see much higher with Rituxan versus cyclophosphamide. And for relapsing disease, it was better with Rituxan, superior. So PR3 ANCA, Rituxan is especially preferred. And then the 115 patient main Ritsan, major relapse at 28 months, much less with the Rituxan group. 500 milligrams at month 0, 6, 12, and 18. So the pulmonary manifestations of ANCA vasculitis, you should know this, it's either diffuse alveolar hemorrhage, that's the most severe, bilateral ground glass opacities. The nodules, pulmonary nodules, are the GPA hallmark. They may cavitate, look like malignancy, and then there's pulmonary capillaritis, microscopic bleeding, maybe bland or hemorrhagic. So ANCA vasculitis, Rituxan replaced Cytoxan for induction, and it's superior in relapsing disease. That was the RAVE trial, New England Journal of Medicine, and then the main Ritsen trial, 2014, showed that Rituxan maintenance 5% versus 29% when we talk about relapse. And what about LAM? It's an older trial, McCormick et al. Where did this come from? Using sirolimus. So LAM is now treatable. LAM with abnormal lung function, which is basically showing obstruction or low DLCO. 89 patients, they looked at sirolimus versus placebo, and you can see the decreased in FEV1. And placebo is a progressive decline. Near complete stabilization with the sirolimus. You treat indefinitely, because after stopping sirolimus, there was a rapid FEV1 decline. You could check VEGF-D greater than 800, and you don't need to biopsy. Young woman, cystic lung disease, VEGF-D greater than 800. Lamb is diagnosed without a biopsy. So that D was transformative. Unfortunately, you can only check it in like one lab in Cincinnati. The mechanism is called the mTOR pathway. mTORC1 overactivation leads to abnormal Lamb cell proliferation in the airways, lymphatics, vessels. Rapamycin inhibits that and halts the Lamb growth. Remember, seeing the smooth muscle in the alveoli is diagnostic. So you get Lamb sirolimus stabilizes FEV1, treat indefinitely, and the mTOR pathway is the mechanism. Then we look at Lazor, Chest 2000, and Cordier in terms of COP. Where do we get this that we should use steroids in COP? Older data, original COP description and treatment was just 16 patients, and then a COP relapse analysis, 48 patients. There's really not a lot of data out there, and we just use it. 65 to 80% steroid responsive within 2 to 4 weeks. COP is one of the most steroid responsive ILDs. Relapse rate is 30 to 58%. Most during the steroid taper. We will see revolutions coming up in terms of what other things we could use besides prednisone, such as Biaxin or erythromycin or azithromycin as well. Migratory, and then maybe even some Nucala. Migratory infiltrates resolve in one area and then they appear in another. So typically we start prednisone 1 milligram per kilogram per day for 4 to 8 weeks, slow taper over 6 to 12 months, not 4 to 6 weeks. Relapsing, classically you add mycophenolate or azathioprine. The diagnostic trap is repeatedly mistaken for bacterial pneumonia. So if you don't respond to antibiotics, then you think of it. Dramatic steroid response within 2 to 4 weeks. Response is diagnostic. Relapse rate is 30 to 58%. That is the laser cohort in 2000. And the longer the taper, the fewer the relapses. So, and then, knowing that you could use medicines now, such as clarithromycin and azithromycin for refractory COP. So now we have mycophenolate across fibrotic ILDs in paper number 9, Swigris, Chest 2006, and Strand, Blue Journal 2014. Notice that these are all older articles. Swigris, mycophenolate in fibrotic non-IPF ILD, which was just talking about 28 patients, and Strand looking at 350 patients. But the forced vital capacity stabilized or improved in 75%. DLCO improved 47%. The MMF versus AZA, MMF had a better trajectory, fewer adverse events. The mechanism why it works, it inhibits de novo purine synthesis, selective suppression of T and B lymphocytes, reduces both cellular and humoral autoimmunity. Where MMF is now preferred, you should know this, it's scleroderma ILD, first line, SLS-II, rheumatoid arthritis ILD, preferred steroid sparing over azathioprine. Myositis ILD is the key agent in combination. So it's triple with steroids and tacrolimus and anti-MDA5, which we're going to get to. NSIP, it's the treatment backbone agent. You treat the inflammatory pattern, and refractory COP, it's added as steroid sparing. So know when it is first line, which is scleroderma ILD. It's the workhorse immunosuppressant in non-IPF fibrotic ILD, stable or improved forced vital capacity in 75%, better than azathioprine across the ILD diagnoses, and you use it in scleroderma, rheumatoid arthritis, myositis in combination, NSIP, and refractory COP. And then this one is the most feared ILD emergency, and that's the anti-MDA5 rapidly progressive ILD, median survival less than 6 months. This is described by Chuji, Rheumatology 2019, and in Seminar of the Arthritis Rheumatology 2020. But the idea is 40 to 60% RP-ILD incidence in anti-MDA5 dermatomyositis. Greater than 1,500 ferritin shows a severe prognosis. You follow that for treatment response biomarker. The 6-month survival went from 30% to 70% with immediate treatment, recognizing the skin findings that are diagnostic, such as skin ulcers over the MCP joints, mechanics hands, Gaucher's papules. Anti-MDA5 antibody is the key serology, and the treatment is high-dose IV steroids, 1 gram pulse for 3 days, tacrolimus, and cyclophosphamide or Rituxan. This is not a disease to manage with rheumatology. Pulmonary alone, both specialties must be at the bedside from day one. Delay of even 48 to 72 hours will change survival. You start triple therapy. So anti-MDA5 RP-ILD is a pulmonary emergency. Triple therapy survival is 30 to 70%. Know the skin findings. Co-manage with rheumatology. Don't wait for antibody confirmation. So the other 4 studies you should know: the INBUILD, we talked about, New England Journal of Medicine 2019. PPF concept applied to non-IPF ILD. So you're using the Nintedanib cardiac sarcoid guidelines in Heart Rhythm 2014. Basically, you use PET scan and cardiac MRI for diagnosis. You treat steroids plus or minus ICD. Fibroneer ILD is nerandomilast and PPF, which included connective tissue disease ILD. So I covered this on my IPF talk, so it's not here. But a PDE4 inhibitor decreases the rate of decline. And then SLE-ILD and Plaquenil, underdiagnosed and underprotected. So here are the key studies once again: SENSCIS, New England Journal of Medicine, SLS, showing that MMF is just as good as Cytoxan and better. CHAMP, Fibrotic, Hypersensitivity, Pneumonitis, should avoid antigen, use MMF, and then if it progresses, use Nintedanib, Predmeth, which is methotrexate versus prednisone, Bauman refractory, so infliximab, and then the rave, that's when we use Rituxan replaces Cytoxan, cyclophosphamide for ANCA vasculitis. And then the mild New England Journal of Medicine, that's where we looked at sirolimus for LAM. Lazor and Cordier a long time ago already showed that the steroids response rate 65 to 80%, but high relapse rate. And then MMF really is the workhorse, and then know about the anti-MDA5 RP-ILD. Thank you for listening.